Good afternoon, everybody. My name is Jorge Borneo, and I welcome you all to the session on semiology at the first North American Epilepsy Congress. So I am an epileptologist from London, Ontario, and my co-chair is Dr. Sharon Whiting, a pediatric epileptologist from the University of Ottawa. So the idea of the session is to discuss, to present three interesting cases. One will be for an adult and the other two will be for pediatric. And we will present a little bit of the video and you have a few minutes to make your comments on the Q&A. And after that, I can discuss that with Dr. Sadler briefly, who will be the first presenter, and then he will complete his presentation to show you what the end result was on that patient. So without further ado, I would like to introduce Dr. Mark Sadler, recently retired professor of medicine neurology at Dalhousie University in Halifax, Nova Scotia, Canada. But he has retained his appointment in the Department of Medicine. He was the medical director of the EEG laboratory and director of the epilepsy program at the Halifax Infirmary from 1988 until July 2020. Dr. Sadler graduated from Dalhousie University Medical School. The majority of his neurology and subspecialty training in EEG and epilepsy was done at the Western University in London, Ontario, Canada. And he spent 5 years as a faculty member at the Memorial University of Newfoundland before returning to Halifax in 1988. Dr. Mark Sadler is a well-known epileptologist whose major clinical interests are the medical management of patients with difficult epilepsy and the pre-surgical investigation for epilepsy surgery. Dr. Mark Sadler is an awesome speaker, and you'll see what I mean with that. So Mark, the podium is yours.
Good afternoon. My name is Mark Sadler. I'm a neurologist in the Division of Neurology at the Halifax Infirmary and the Department of Medicine at Dalhousie University in Halifax, Nova Scotia. And I apologize that I don't have a video of myself presenting this. So we will just have to do with my voice and the slides. I want to thank the organizers and the course chairs for the invitation to present at the semiology session, and I have a case that I hope will be of interest to you. I have no disclosures relevant to this presentation. I came up with an attempt at a catchy title, A Man Who Kept Swiping Left. If you don't get the cultural reference, you can look it up and then it will make sense with respect to why I called this presentation by that name. I'll start with a description of the patient's clinical presentation. We will then stop the video for a while to get questions and comments that will be run by the session chairs, and I will finish with investigations, the clinical course, and comments. This is a 65-year-old man who in 2012 presented with a nocturnal tonic-clonic seizure out of sleep. He was seen by a neurologist and treatment was started. He had absolutely no further difficulties over the next 7 years while he was taking his lamotrigine reliably. But he presented in June 2019, last year, with the constellation of symptoms that will be the subject really of the semiology session. He came to the emergency department with a visual complaint, and while he was being assessed, he had a witnessed tonic-clonic seizure, only the second that he had ever had, and ended up being admitted to the neurology service. But the features of interest are as follows. The reason he came to the emergency department is because he was having recurrent visual hallucinations of a human face. Typically, he would see a face, although on some occasions it was just the outline of a face. It would appear abruptly in the center of his vision, and then the image would move quite quickly off to the left-hand side. The total duration of the image being present is perhaps 2 seconds or so, that limited his ability to give us fine details. But as soon as that image disappeared, he would have another face, a completely different face, appear directly in front of him, sweep to the left, and this would be the sequence would occur over and over again for 1 minute, 3 minutes, or perhaps as long as 5 minutes before it would spontaneously stop. The problem was that this sequence was recurring every 10 minutes to 2 hours through the day. The faces were described as Caucasian, although sometimes he thought there were some Asian features. The faces were not people known to him, and they were not famous people, anybody that I could identify, etc. When he stopped having one of the acute clusters, there was a short period of time lasting several minutes during which he would have an incomplete left hemianopia, but in addition, the interesting phenomena that he was no longer able to recognize the faces of people in front of him. The very first time this happened was in the presence of his wife, and he suddenly could not recognize who his wife was until she spoke to him. At no time during this presentation, other than his single tonic-clonic seizure, was there any alteration of consciousness at any time, perfectly lucid, talking, mental status exam, otherwise completely unremarkable. So at that point, we will pause the video and get your comments.
Thanks. It's me live now. Jorge, you want to
I'm here.
take it? Okay, very good.
So, but I cannot open my video anyway. So anybody would like to make any comments? The Q&A are open for comments or questions. The interesting thing is that the faces are not the same face every time they happen, eh, Mark?
Correct.
So there are different faces. And was there any other feature? Somebody's asking in the Q&A, is it palinopsia?
Well, this part is not palinopsia. Oh, no, it is not palinopsia in the sense that the images are not the same ones repetitively.
Okay.
Completely different facial features, facial outlines. Sometimes they were complete faces. Other times they would be just an outline of a face or look like a face shape. But as I said in the video, these things were quick, perhaps only a couple of seconds. So he was unable, this is a highly intelligent individual, and he could not give a lot of details about each individual face.
Any triggers to these seizures, Mark?
No, and he had been completely seizure-free for 7 years, and without any obvious precipitant, jumped into this state.
Does he have any other ongoing medical condition, perhaps diabetes or hypertension?
Nothing relevant at all. Nope.
Any extrapyramidal features in his examination?
No.
Okay, and there is no turning of the head or the eyes before the bilateral tonic-clonic seizure?
That was we didn't get a feature of that in the emerge department. It said he had probably one out of sleep many years ago, then a witnessed one out of sleep, and then the only one that he ever had again was 7 years later in the emerge department, and it wasn't commented on.
The audience is already commenting on localization of the seizure. There is a comment from Dr. Agashi, right parieto occipital. And I guess she's mentioning this because the visual phenomena is much more complex. So it's not coming from primary visual cortex, but rather secondary visual cortex. And this appears to be more parieto occipital. Maybe she's referring to it because of the fact that he was able to recognize the voice of the wife, but she couldn't see her, I guess. I don't know. Would you care to make more comments on the Q&A, Dr. Agashi, on why would you go for that localization? Anybody else would like to make a comment about localization? There are more questions here. Has there been any new onset of headaches or cognitive decline in this patient, Mark?
No.
Any parietal lobe features like a spatial disorientation on examination?
None.
Okay, now Dr. Guyan is now jumping into saying that this is, instead of parieto occipital, more posterior temporal. Another question is...
we should also ask for people the laterality.
Yeah. right posterior temporal, Dr. Guyen, right parietal occipital, the first one, and now there is a comment on right temporoparietal junction. And Dr. Alata said it comes from the posterior quadrant, posterior temporal, obviously from the right side. Mary McAndrews mentioned fusiform face area on the right. Aha. Would you care to comment? And there is also right fusiform gyrus from Dr. Purohit. So I don't know if they would like to comment a bit more on the Q&A regarding that. Dr. Agachi said more of an association visual cortex. Another thought would be temporoccipital fusiform. And Dr. Liu said, was the prosopagnosia intermittent as well? Was there prosopagnosia on examination?
There was only prosopoagnosia as a postictal phenomena lasting variable minutes after one of his clusters.
Good, excellent, great questions. Keep going, guys. There is another one, fusiform, because they seem to be so discrete. That's what Mary McAndrews is saying. Another comment is, as he had posictal prosopagnosia, it should be more temporoccipital, possibly right side. Has there been any changes in the blood pressure? Dr. Alcalde is concerning about the possibility of a press-like phenomena.
That's interesting, but no. And
No.
the subsequent imaging did not disclose press.
Okay, Richard Debian is quoting another man who mistook his wife for a hat. That's a good one.
That would not be Richard, but
it is Richard Debian.
oh no, Richard would never mistake his wife for a hat.
No, that's for sure. So another question about posictal prosopagnosia. Yeah, the answer was yes, and that was a posictal phenomenon. So it seems that the consensus so far, from what I see, it appears to be right temporoccipital in terms of localization, and the some of the attendees are pointing to the right fusiform gyrus, and no clear explanation. The only comment was that the fusiform, because the I guess it seems so discrete, the semiology, that it would point towards that area.
Okay. So, no, the audience is good. This is a sharp crowd.
Yeah.
We'll roll the tape in a second here, and then at the end, I can make some additional comments if there are anything further. So I'll stop my video, and we can start the tape again.
Thank you for your thoughts on this, and now I'll tell you what happened and as a result of his investigations and so on. First of all, he had an EEG done on the day of admission that demonstrated that he was in non-convulsive status epilepticus. Shown on this slide is a seizure in the right posterior head region characterized by a high-frequency rhythm noted at T6:02 and to some extent at P4. And several seconds after the electrographic onset, the patient spontaneously described seeing one of the faces in front of him. During the 30-minute recording, he had 3 or 4 episodes of this nature. With respect to his imaging, he had an MRI scan that showed a cerebral cavernous malformation, and this was known to be present, him having had this discovered on a previous MRI 7 years ago when he first presented with his tonic-clonic seizure that led to him being started on lamotrigine. Importantly, however, despite repetitive viewings in 2 consecutive MRs on the current admission, there was no change in the size of the cavernous malformation, no evidence of any blood products or anything like that. This slide demonstrates the location of the cavernous malformation in the right posterior inferior region of the temporal lobe, abutting in the region of the fusiform gyrus. His clinical course was complex in the sense that he was essentially in non-convulsive status epilepticus for the next 3 weeks, during which time he had sequential anti-seizure medications added, all of which caused him some side effects. There was some minimal response of the seizures to treatment, and ultimately it was elected to proceed with a resection the cavernous malformation. This was performed by one of the neurosurgeons at our center, Dr. David Clark, who resected the lesion only. The patient tolerated the procedure extremely well with no known post-operative deficits. He had a couple of attacks as described here where he had some water turning red while he was washing his hands on day 2 and 3, but subsequently has been 100% seizure free on modest doses of lamotrigine and levetiracetam. So that is our case, and I thank you for your comments and attention.
And I think we can have a couple of questions. We still have 4 minutes until the end of this particular presentation. The questions from the audience, did you do intraoperative ECOG to map out the seizures?
No, we talked about that, and Dr. Clark said, "Look, let's just get this done." And a different David Clark, by the way, than who will be presenting later. Yeah, so it was. This is a man that I thought was extremely unique in my experience. I was unable to find in the literature any case of spontaneous facial hallucinations like this with confirmation by simultaneous depth electrode or subdural recordings. There's a number of case reports, probably half a dozen or so, of people with depth electrodes or subdural electrodes in the region of the fusiform gyrus who have undergone extensive electrophysiologic testing, including stimulation, that reproduced facial features very much like this. But we could not find a spontaneous, as somebody who has actually had seizures like this for which they were recorded with intracranial electrodes. So I thought it was quite unique. The other thing was that was perplexing and unsolved was what precipitated the status. There was absolutely nothing in his history. He was a very reliable guy. Nothing really happened. Well, I must admit, I thought we were going to see some new blood products on his MR and change in size or something that had precipitated, and there was absolutely nothing. And once this got going, we just well, as the story was, as you said, so we had an older man. We talked about older onset epilepsy last evening in these sessions, who went on to epilepsy surgery as a treatment for non-convulsive status epilepticus. So the constellation I thought might be of interest to the audience.
There are a couple of questions, Mark, in the last 2 minutes. Was there any postoperative prosopagnosia or any facial recognition complications following surgery?
Yeah, no, not obvious. Now, we had planned to have them seen in follow-up neuropsychology testing with the appropriate famous faces recognition and so forth, but the COVID fiasco got in the way of doing that.
So great case. I remember when I was a resident had a similar case, but the patient didn't have a lesion. He had diabetes and went into one of those non-ketotic hyperosmolar state, and his seizure presented with the image of his brother-in-law calling him from inside a pot, which was very interesting. And we were able to capture that to be from the same area, but once we controlled the sugars, he stopped having the seizure. So thank you so much, Mark. That was great as always.
Thank you.
And I'm going to pass the post now to Dr. Sharon Whiting, who is from the University of Ottawa and will be doing the presentation of the following speaker. Thank you.
Good afternoon, everyone. Our second speaker today is Dr. Dave Clark, who is Chief of Pediatric Epilepsy at the Dell Children's Center at University of Texas in Austin. And he trained at my alma mater, University of the West Indies, and subsequently went on to University of Michigan and then the University of Toronto for epilepsy. He's the incoming president of the Epilepsy Society of the Caribbean and also on the Epilepsy Leadership Board. And he's going to present a pediatric case. We will follow the same instructions as for the first case that was outlined. Enter your questions regarding where you think the lesion is coming from in the question and answer. Thank you. Dave?
I'd like to thank the organizers for allowing me to speak to this very important topic, the importance of seizure semiology. But all may not be what it seems. So, since 1929, we've been looking at this EEG. And it's great, we still use it, scalp EEG. But over the last few decades, we've gotten all these nice fancy techniques, be it functional MRI, SPECT, PET, magnetoencephalography, TMS. But with all of that, including EEG, we always go back to the age-old seizure semiology. It starts everything, it's optimal. It helps us to determine not only the semiology, but potentially the epilepsy syndrome and or surgical candidacy. So I thought I'd choose that I think may be pertinent not only for epileptologists, but also neurologists and primary care physicians. A 5-year-old female, drug-resistant epilepsy, monozygotic diamniotic twin, but normal development, going along nicely until about 4 years of age, when she had a prolonged focal seizure involving primarily the left side as per parental history. The EEG showed predominantly paracentral discharges, and this occurred primarily while awake. But look at what happens when she goes to sleep. You have more Rolandic discharges, C4 field involving P4 and even T4 on the right side. So it extends to temporal. But something is different here. It's not always synchronous with that seen over the paramedian area. So you have discharges that are parallel and synchronous, and then you have sometimes discharges independently seen at CZ. So is it childhood epilepsy with centrotemporal spikes? Let's look at these seizures. The patients seem to have posturing of both upper and lower extremity on the left side first. But the face is not involved at onset. Look down here. See, later the face gets involved. She wakes up. She's upset at first. And with this one, she evolves to involving both sides. She also has some episodes of staring in which she places hand to mouth primarily while awake, which makes sense. You know, when you go to sleep on those transitions, more recruitment, larger, more involved seizures.
And can you...
And ictally, it looks...
Presently? Thanks. Go back one slide, please. Go back a wee bit. Perfect. So here I'd like to stop, ask people what they think about the ictal semiology of this patient. And I cheated a bit because of the difficulty with kids. Please ask questions pertaining to just about anything related to that.
So, Dave, I'll ask the first question. So you mentioned that these were drug-resistant seizures. Did the semiology change between the ages of 4 and 5 or remain the same?
Oh, amazing question. So initially when she started off, they didn't even realize they were seizures. She'd sometimes wince out in pain, and sometimes she'd take her hand and raise it to her mouth. Then with evolution, she started having the seizures that you saw there, usually with involvement of lower extremity just preceding upper extremity proximally.
Okay, all right. Well, I notice we have no brave questions going forward. Anybody has any thought as to where this seizure could be coming from? Okay, so we have a question. Dave, are these happening only during sleep? And is there tonic posturing at the beginning?
Actually, two good questions. During awake, when she has them, it's usually drowsiness. And that's the only time you see the one in which she initiates with more crying and reaching for her face. During the evening, rapidly, you have tonic posturing with subtle clonic movement of both upper and lower extremity, and then they extend to face. Face is not initially involved. You may have a little bit of drooling, but that's late.
Okay. All right. What about the duration of the event, Dave?
Yeah, so most events last less than 60 seconds. She has had some in which they're a bit more prolonged. And after about maybe 90 seconds, when she has them, it's more relaxation, a little bit confused, and the discharge actually goes on paracentral just for a few more seconds.
Okay, so Olga has said contralateral SMA or primary motor cortex. And Dr. Atsubu is talking about a Jacksonian march with the seizure. Is that present?
The only Jacksonian nature of the march in my mind is when it evolves to the facial clonic, and that tends to come a bit late. But remember, both upper and lower extremity proximally tends to occur immediately at the same time. Becomes
Okay.
and then spreads contralateral.
All right.
I want to stick a little pin here, and I've stressed it 3 times now. She usually winces out in some pain prior, and sometimes she has a bit of drooling.
Right. And so someone is asking, are there sensory feelings? And if initial presentation with pain, is it sensory motor?
Very good question. There seems to be sensory feeling, but to try and extract that from a 5-year-old, what she usually does, however, which suggests sensory feeling, in that after the seizure, she sometimes reaches down and rubs her leg. And on other occasions, her mother says she has described some type of discomfort in her back.
Any rubbing of her hand together?
No, that does not occur.
Okay. Mary McAndrews suggests maybe it's in the insula. And that's a suggestion.
All very good suggestions.
Okay, another question.
Why the insula? Why the insula?
Dr. McAndrew, maybe you might want to make a comment about the insula while I'm reading the rest of this. So one person thought it was posterior epilepsy with frontal propagation, looking at the topography of the spikes. Another question is there postictal, does she have a postictal headache and any indication of a visual aura? For instance,
indication of a visual aura, but for a 5-year-old, that's also very difficult to tease out and difficult to ask her. She has not had a postictal headache, but one little thing I slipped in at the end, she does have what seems to be weakness involving her hemibody. That's involved, but very, very short-lived, about 1 to 2 minutes. It's very difficult to ascertain if it's actually weakness or maybe, say, a spatial attention thing, because when she reaches out, it's distorted.
Okay. So Mary McAndrews is coming back on saying the drooling and the pain was why she suggested the insula.
Very good. We shall see.
We shall see. Okay. Well, I think that's I think that we should then move on, Dave, if you're okay.
That's perfectly fine. And ictally, it looks somewhat analogous. You see the central activity, but a wider field of disruption involving the centrotemporal area. So it starts paramedian central, and it extends apart from the midline, involving and disrupting primarily the right hemisphere, shifted more posteriorly. So we're looking at a much wider field, not only the perirolandic area, but across the midline. And look at the seizure. The seizure involves the entire hemibody, relative sparing of the face. What are we dealing with? And then we hear this patient has failed 4 medicines. So when she comes to me, I'm thinking, is it really Rolandic epilepsy? It's definitely not classic, involving that hemiphase. And it's also not involving a very focal site. That one eye with an MRI specific to this region in the Rolandic area, in this kid with tuberous sclerosis. Could it be malignant Rolandic Sylvian epilepsy, as Otsubo and others have described? Well, it's unilateral, makes sense. What does the MRI show? In this case, the MRI shows a deeper chronic ischemia of the right basal ganglia and periventricular encephalomalacia. Now, on its own, doesn't mean too much to me. But on further looking at the MRI, there's a region here that seems atypical. Some blurring of the gray-white junction, crowding of the neurons, possibly dysplasia. And DTI and tractography shows the same. This is just not as smooth as the contralateral gray-white region. And there's some crowding of the motor activity. So here we go with this blurring as I had suggested before. You know, with malignant Rolandic epilepsy, spikes and the magnetoencephalogram helps. So let's look at that. With the MEG, really doesn't help as much because it shows succinctly primarily somatosensory motor foot being involved. And if that is the case, we should have had clonic or even some tonic activity of the foot and perhaps maybe a Jacksonian type march. So it doesn't exactly fit. We know her language is on the left side, which is very important, won't affect that function. So what do we do in this case? EEG, somewhat classic, not really. MRI abnormal, shouldn't be seen in Rolandic. And then there's MEG. Do we do nothing? I don't think that's plausible. Like this volcano here in Sister Island from where I come from in Montserrat, it's exploding. We can't leave it alone. Do we keep trying medicines? Well, we know failure of 2-4 medicines, we're not going to get much success. Vagus nerve stimulator, dietary, palliative. RNS, not a bad idea. But how about if we take another look? How about if we sample where the evolution and circuitry leads us? Primarily sampling that deep dysplastic area and that motor area of MEG. And focusing on that peri-insular area, the long gyrus, just because of that spread and that grimacing just prior to and after with the crying. Could that be some semblance of pain? Sure enough, the depth electrode shows us PI, that's the peri-insular area here, the posterior insula, and then the PMP, that's the posterior, parietal mid area going down to the insula. It evolves from there and spreading from that insular region, it spreads up and engages that motor strip. Tight circuit, but it takes a few seconds, 3 seconds. See that evolution? And it picks up. And only after a while that is engaged the face does it spread to the facial motor area that you tend to see that opercular involvement with Rolandic epilepsy. And that explains the semiology, doesn't it? Starting in that peri-insular area posteriorly, long gyrus, going to somatosensory motor region, and that posturing, not that focal clonic, not that evolution. And we picked up even some subtle seizures, the ones in which she reaches out and grabs and cries with total awareness. So again, going to that region. So what do you do there? This just shows you exactly where it activates and how it spreads. How about making sure this is the sensory area here, parietal, and she pulls back, and then we stimulate, and we can determine where motor foot is down here. But notice it doesn't evolve to seizure. And the circuit seems to be going in one direction, in that when you stimulate the area close to the dysplasia, it activates that motor area. But when you stimulate the motor area, it doesn't go in the other direction. So, you know, many people would do surgery. We decided to do ablation, and we ablated this region down too, but not involving the motor area, with the assumption that could the basal ganglia be involved? Well, putamen goes to motor, and that's where the stroke is. But more so, we assume it's coming from that long gyrus, as we saw with the EEG, and then it spreads to the somatosensory and eloquent cortex. So fascinating case of what we thought was traditional Rolandic, but by the time they got to us, they were telling us a different story. So in summary, with this case, the seizure semiology led us, as Lodos would suggest. And it's important to know this because it's very easy to identify. Take a great history. It helped us to determine the circuitry of what was going on. So semiology, semiology, semiology. You question the epilepsy syndrome, then take another look. Remember, good intentions aren't enough, but there's an essential quality for success in medicine: humility. And I will stop there, and I'll answer any questions that you may have.
So Dr. Connolly had a question. Is the child aware? Is there speech arrest or vocalization? I think this was left over from before.
Yeah, no, there was no speech arrest, and in most events, the child was aware of what was going on.
Okay. So can you tell us then, Dave, how the child is doing?
Yeah, so she's 3 months out now. I'm still very concerned because she did have on ECOG occasional discharges coming from that paracentral area. And my fear is the deeper area involved spread so quickly was that involved. But fingers crossed, within the first 2 weeks, she had 2 seizures, mainly clonic, lower extremity, and she hasn't had any since. But I'll keep you guys up to date.
Okay. So Dr. Nguyen is asking, what are the immediate or long-term post-op complications? And did you place Singlet and SMA leads? Yeah,
so we did not place SMA leads, and I thought this would come because we wondered if to place that lead itself. And the evolution does seem that way, and it could spread from parietal. So that's a very good question. As a matter of fact, the debate between surgery and ablation was the fact that we could go so close and with tractography not get into that motor region. And she actually had no sequelae. She's actually now walking better than she had before the ablation.
Okay. So a question here, given the relative success of your intervention, do you foresee ablation or LIT as a potential treatment for continuous slow spike wave in sleep, ESES?
That's another excellent question. It would be very difficult at this time unless you find a specific target. So remember with LIT, either one, it's only within a few centimeters that you could actually ablate. So unless you can find a specific target, I don't foresee what had happened with, say, prior surgeries for ESES.
Okay. There's a final question from Dr. Suntarumpan. Can you please repeat again why we think it is from the insula? So maybe, sure, Dave, in this last minute that you could sum up again where you think, because the seizure gave a very nice progression through. So maybe you could leave us with that, sure, as the final thing.
Sure, not a problem at all. So I'll address posterior insula first. That tends to go to somatosensory. But with posterior insula is unique for primarily pain. The insula itself tend to have drooling, and they sometimes have autonomic features. Whereas the anterior insula tends to go to prefrontal and supplementary motor. but with the spread itself, spreading to that somatosensory area, that's why I suggested that. I thought the SMA question was a very good one, because if the seizure evolves and goes to parietal, it can very rapidly spread longitudinal, fasciculus, and other means to the SMA. So that was an excellent question, and doing it again, I probably would have placed the depth electrode there. So
All right.
questions, and you guys won the money. Thanks.
All right, wonderful input from the audience. Thank you so much, Dave. So our final case today is by Dr. Appendino, who is from the University of Calgary, a pediatric neurologist at the University of Calgary. And he trained in pediatric neurology and epilepsy at the University of Toronto at the Hospital for Sick Children. And then subsequently went to Manitoba and now is in Calgary, where he runs a neurometabolic program, and it also runs a pediatric epilepsy fellowship. So Dr. Appendino.
Hello, this is Juan Appendino. I'm a pediatric epileptologist at Alberta Children's Hospital in Calgary, Alberta, in Canada. For those that don't know me, I will share with you an experience that we have as a team with one of our cases. We hope you will enjoy and the discussion will be fruitful. There are no conflict of interest to report. Here is an overview of what I'm hoping to achieve in the next few minutes. We will review the case, some videos. We'll go for this overall discussion of potential seizure onset, as we usually do, and then we will expand a little more the further story, results, and conclusions. So this is a patient who is 7-year-old. She had severe HIE with bilateral brain injury. As you can see, left more than right hemisphere involvement. She has the developmental delays. She's sitting independently, but walking with the help of a walker, and is partially blind, and she has no expressive language expression. As well, she is left-handed due to the asymmetry of the injuries. She has failed to several medications, including rufinamide, topiramate, perampanel, phenytoin, levetiracetam, valproic acid, clobazam, oxcarbazepine, and lamotrigine. She has not been tried on ketogenic diet, neither we have offered yet vagus nerve stimulator, as she had focal motor seizures, which we were hopeful to help with receptive surgery. We will go over the seizures that sometimes evolve into joint-tonic-clonic. They occasionally lasted up to 45 minutes. I'm not going to describe the seizure semiology, as you can watch it on the videos. As you can see, she, from sleep, had an abrupt onset of right arm tonic posturing, and you will see the left arm is slightly asymmetric, as this seizure shows clearly. You can see that she have still left arm dominance, but the right arm is dystonic, extended, and asymmetric posturing. But when we had her EEG on as one of the seizures, this is from sleep, the first seizure you observe, she has an abrupt onset with bilateral synchronic and no clear lateralization on the EEG. So here is when we pause and we follow our Mark Twain advice, a very own Mark Twain advice. A pause is far more effective than the right word. Thank you very much. Can you hear me?
Okay, so
Great.
yeah, we can hear you. So at this point, as you say, we're going to pause and ask the audience, where do they think the seizure is originating from, and the symptomatogenic zone?
Mhm. Yeah.
So
Go ahead,
Dr.
Sharon.
Otsubo is asking, is there one type of seizure in the history or more than one type?
Thank you for the question. Actually, she has a single type that evolves with focal motor and sometimes go to bilateral synchronic activity. But the focal motor can last up to 40 minutes. We are not aware about any sensory seizures, as she has not complained and she cannot. But during our monitoring, we only captured this type of seizure. She has had in the past some myoclonic jerks on the right area, but not at the current time or by the time that we saw her in the EMU.
Okay, so Dr. Nguyen is asking for what's happening interictally in terms of spikes on the
Thank
EEG.
you. Obviously, that's a very good question coming from a neurophysiologist as well. So she has actually bilateral interictal discharges with lateralization towards the left hemisphere, but they're mainly during sleep, bilateral independent left and right frontal, as well as bilateral synchronic as at the very onset of the seizure we just saw.
Okay, so one person has suggested that the tonic posturing could be from the primary motor area.
Mm-hmm.
And the question that's following, is the child ambulatory and does she fall with her seizures?
The child is not independently ambulatory. She walks with the help of a walker, but she mainly remains sitting. And when she is on the walker, if she's not strapped to the walker, she may fall because of the seizure. And those that have mentioned about the motor area, I would ask whether they think it's SMA or premotor, left, right, any other?
So one person has said SMA. Dr. Otsuba says paroxysmal tonic indicate SMA.
Mm-hmm.
And another question that's coming up is, what's the EEG during REM sleep?
Regarding interictal activity or regarding sleep features that but anyway, so
regarding the EEG interictal, I would say.
Yeah, I would think so too. As I mentioned before, they seem to be more frontal, but there was no clear difference between left and right. They were quite similar interictally in terms of activity, and then at times bilateral synchronic with higher amplitude in bifrontal areas.
Okay. So Priya suggests that starting with the arousal and then followed with right and then subsequent left arm extension and tonic posturing and some hypermotor movement seem closer to the midline or interhemispheric region, possibly left greater than right, possibly the SMA.
Fair question and fair comment. That was our thought as well. More even so, keeping in mind the asymmetry in the MRI findings, where the left hemisphere seemed to have been more compromised with the hypoxia, and there were more scar tissues observed, as well as that she has is a left hand dominant, suggesting a more dominant right hemisphere.
Okay. An interesting question. How is her awareness level during the seizure? In lateral frontal, it might be affected due to involvement of the right frontal eye fields. However, in supplementary SMA, her awareness should be normal. So do you know what's happening with her awareness? It's quite
Yeah,
difficult
so
in this age group.
exactly. So, but thank you. It's a great comment and a great question. So her awareness seems to be preserved at some degree as she complains and she seems to be moaning and a little more bothered by the seizure. She obviously cannot verbalize, but she certainly settles when mom gets close to her and try to calm her down. So she seemed to be responsive. So we thought her awareness was somewhat preserved.
Somewhat preserved. Okay. There was a question when you mentioned that she also had focal seizures that would go to bilateral and last as long as 40 minutes. Is that right?
Yeah, so it was unilateral to 40, 45 minutes, non-responsive to midazolam ×2, fosphenytoin intramuscular ×1, and then gradually start settling down after that. But really, we were very concerned about these seizures because of the length they had. So. Yeah, good point.
And again, I'll ask the question that I'd asked of Dave. Was the seizure semiology the same? She's now 7 years, or had there been changes over time?
That's a very fair question. At the beginning, they were shorter, and they as I mentioned, there were some myoclonic jerks also on the right side as well. But towards by the time we saw her in the LTM monitoring unit by 5 years of age or so, she had a quite consistent semiology with the right arm extension, very tonic, dystonic posturing, and lasting that long. So it was very sustained for the previous a few months. We didn't wait too long for the seizures to evolve because of the length and severity of the seizures.
Okay. So I think the last person, Dr. Perez, says in the first video, semiology appears left SMA. Has she had any other seizure type in the first year of life?
Well, she had neonatal seizures because of the HIE. She was very sick, very severe HIE. And then she did not have any seizures until later in life at about 3 years of age.
3 years. Okay. So I think that the consensus here seems to be premotor SMA and on the left side from the discussion on the chat. And there are no further questions. So maybe you could let us know what the answer is.
Yeah, well, let's keep moving on with the presentation, and let's see. We also thought that, guys. So, what are your thoughts? Where would this seizure be originating from? I'm guessing you have had time to think about, and I gave you almost 20 seconds. So we also thought the onset, according to the literature, the anatomy, and the physiology that we have learned, that likely is the left frontal mesial areas, particularly some supplementary motor area or pre-SMA. But given the lack of laterality on the EEG, we were not sure whether or not to proceed with resection, and given the delays, invasive was slightly concerning to be offered. Thus, we, or as you probably guess, we offer corpus callosotomy that was performed, and she was interestingly seizure-free for 8 weeks after the corpus callosotomy. Nonetheless, her seizures recurred, and her semiology after the corpus callosotomy remained quite similar. As you saw, the right arm becomes very dystonic, painful. She complains. She grabs the tonic arm with the left hand, still suggesting left hemispheric onset. But her EEG, despite the corpus callosotomy, remained quite non-lateralizing. Thus, we offer left frontoparietal disconnection or anterior disconnection that led to 10 weeks of seizure freedom. This was very reassuring and very optimistic for the family. However, when the seizures relapsed, was quite devastating. And despite these seizures, the surgeries that we offer. Interestingly, after the surgery, the seizures became even longer and at times almost an hour of focal status epilepticus, which led us to finally offer invasive monitoring. The child was older and was able to tolerate better by then. So we found this on our stereo EEG. So her seizures are after the left anterior disconnection. Her right arm continued being tonic, the left being used for control her right arm tonic. The seizures became very prolonged with a left head deviation toward and right arm dystonic posturing. In order to orient the audience, these are left hemisphere, these are right hemispheric leads. I'm showing the right hemisphere leads. As you can see, we were quite surprised in learning that her seizures had a right hemispheric onset, particularly in the right middle cingulate, which was in the pre-motor cortex, and we confirm this finding with a cortical stimulation. Here we are stimulating the right middle cingulate electrodes 4 to 5, which are very cortical. Pay attention to the arm. Here we elicit with the right hemisphere. So you can see with the right hemispheric stimulation, we were able to elicit right hemispheric, right arm extension with slightly left head deviating to the left. She also had electrical seizures coming from the left middle orbitofrontal leads that were obviously asymptomatic due to the previous disconnection. So this case taught us quite an interesting finding, and HIE was not really part of previous investigations regarding hemiplegia and how the reorganization of the cortex and the white matter became to be after an early onset injury. However, we have learned from our case that an asymmetric injury caused by HIE can again lead to ipsilateral reorganization and reconnection, or sustaining the ipsilateral connections. Stout et al. Back in 2004 already, with transcranial magnetic stimulation and brain MRI, was able to find in 34 cases with cerebral palsy and unilateral lesions, that if the lesion left some white matter connection, there was still a contralateral organization and representation of the cortex. However, when the injury left no white matter connection, the brain had ipsilateral representation as well as contralateral as normally would have. And he found that the earlier the injury was, the more possible this reorganization would happen. However, the later it did, particularly for the hen dominant activity, was not the case. And ARTC with gray matter, I found gray matter thickening on those cases. In conclusion, when assessing children for receptive epilepsy surgery with past medical history of early brain injury, as perinatal HIE, consider cortical reorganization as a possible cause of false electroclinical localization. Thank you very much, and I'd be happy to answer any questions.
Right, so I think we're at the very end, so we will ask one quick question from Dr. Otsubu is, had you done things like PET, MEG, Ictal, SPECT, etc. Before you did the final surgery or even prior surgery?
Thank you, very good question. The patient behavior is quite challenging. We should have done that with sedation and anesthesia. Given the diffuse injury, the PET, the interictal PET would be probably the one that we could do more easily. Would have been not that reliable due to the bilateral injury. So that's why we ended up doing bilateral stereo EEG implantation. Yeah.
Okay, Dr. Borneo.
Yeah, thank you very much to the speakers. Great cases. And other than thank you, those who attended the session. We run these sessions every year at the Canadian League Against Epilepsy meetings, and we decided to send a proposal to have it in this North American meeting, and I hope it continues in every meeting. And we have 2 pediatric cases, 1 adult case. Hopefully the next time will be the other way around, 2 adult, 1 pediatric. I don't know.
Dr. Goodyen is complaining about, or actually being thankful that doesn't see kids. So,
Oh, okay.
So thank you very much. And I don't know if Dr. Whiting had some final words before we end.
Well, the final words, I'll echo what Dave said. Semiology, good history is key before you embark on anything.
Be careful with the reorganization, though.
Exactly. Keeping that in mind. Keeping that in mind.
Thank you very much.
Thank you, everybody.
Thanks, guys.
Thank you very much.
Have a good rest of the conference.
Thank
Good
you.
seeing you all. Bye-bye.
Bye-bye.